It's my pleasure to announce the next speaker, Rob Horne. Rob is Professor of Behavioral Medicine at University College London. His research focuses on the role of psychological and behavioral factors in explaining variations in response to treatment. Rob trained in pharmacy and health psychology. A key theme in this research is the understanding of the patient and the public perspective of illness and treatment, and how this can be applied to help to get the best from essential treatments for the benefit of individuals and society. His current interest centers on the development of interventions to support adherence to essential treatments and optimize the non-specific effects of medicine. Rob will talk about digital technologies to improve adherence, limitations and opportunities. Rob.
Thank you very much. It's a pleasure to be with you today. And I think my talk will follow on quite logically from the previous one, actually. So these are my disclosures. And non-adherence, first thing to say really is this is a ubiquitous problem in healthcare. The WHO, in a classic review done over 20 years ago, estimated that 50% of prescriptions for long-term conditions are not taken as advised. And if we take a leap of faith and imagine that the prescription was appropriate, then that results in increased morbidity, mortality, and healthcare costs. And all three stakeholders in the virtuous triangle illustrated there are damaged by non-adherence: patients, the healthcare providers, and the pharma industry. But yet effective interventions are elusive. And if we look, for example, at this, it's the same issue with technologies, okay, as well as medicines. So if, for example, if we look at the challenges of digital technologies to support adherence, there's a choice overload, very many apps, 250 added every day, but with little evidence of clinical impact, and low rates of initiation among patients, and low rates of adherence when people do initiate, so very few people stick with it. So we have this ubiquitous adherence problem. And as the previous speaker illustrated, there are a number of really difficult challenges that explain why many interventions don't work. And I just want to outline two key principal challenges. The first one is that adherence rates vary, not just between patients, but within the same patient over time and across treatment. How many of us have ever been non-adherent to a treatment? Quick show of hands. Yeah, it's around 50%, okay? And non-adherence, I think, should be seen as the norm rather than the exception. Now, that's an inconvenient issue because it means that if we look at the problem through a lens of socio-demographics or trait characteristics like age, gender, intelligence, these are not consistent predictors of adherence. They only identify whether someone might be at risk of non-adherence, but they don't say why, and they don't explain why a person might be adherent to one aspect of their treatment and not to others. So in order to understand the problem, we need to understand the interaction between a given patient and a particular treatment or device, and that's a challenge. The second one is that we have an information action gap, as the previous speaker clearly illustrated. So just giving clear instructions and information doesn't influence behavior. And that's a fundamental challenge. Now, why is that? How can we understand that? In a recent review published, I think, about 2 years ago that looked across long-term conditions and identified proven correlates of non-adherence to medicines, there were over 800 established correlates. So I'm just going to go through each of them very quickly. So we need a model, okay, some kind of framework to capture that. And this is a very simple one. All of those reasons boil down to two things. There are two reasons why people don't follow advice. They can't or they don't want to. Now that sounds, entirely obvious, but failure to apply that is why we in the healthcare system lose billions globally because of non-adherence. And if we dig a little bit deeper into that can't, don't, want to paradigm, we see that non-adherence can be separated into two overlapping behaviors. On the right-hand side, it might be unintentional. The person wants to do it, but they can't because of barriers beyond their control. They may not know how, they may not have learnt the technique, they may not have been able to establish a routine, they might not be able to afford the treatment. These are limitations in ability, limitations in capability and resources. And this is the practicalities of adherence. And much of what we do, particularly around digital support to adherence, is located in this orange circle. Even if we frame teaching as learning, which I agree with, it's still pretty much located in the orange circle. And that's one of the reasons why our interventions have limited and often short-lived effects. Because much of the non-adherence is not because the patient can't, it's because they don't want to. And actually, we need to understand the blue circle in much greater clarity to be able to address this problem. There, we're looking at intentional behaviors, and we need to understand the factors that determine motivation to start and continue with a treatment. It's the perceptions, the beliefs, emotions, and background biases that cause an individual to conclude that it is a good idea for me to start and continue to follow this advice. So how can we understand that in more detail? And then what implications does that have for digital technologies that are designed to improve adherence? So treatment beliefs are the missing link here. How we really think about illness and treatment and how that determines our behavior is a key consideration in this space. And I want to introduce a very simple framework that can be used to guide interventions that try to enhance patients' motivation as well as their ability. So this is called the Necessity Concerns Framework. And it purports that there are two key beliefs that will influence whether we think it's a good idea for us to take a treatment or not. And the two beliefs are necessity and concerns. Now, necessity is not the same as efficacy or benefit. It's related. We often communicate treatments or even devices in terms of the benefit that is likely to be accrued, and we reassure people about the efficacy. But actually, necessity beliefs sit above that evaluation, and they can be thought of as the answer to two questions that we ask ourselves. The first one is, do I really need to do this to achieve something that's important to me? And the second question is, can I get away without doing it? And we ask that second question for two reasons. One is that most of us are creatures of habit, and we don't want to change anything or do anything that we don't want to do. But also when it comes to medication, it's very rarely viewed as a neutral or a totally beneficial proposition. Most people have concerns about taking medicines, and those concerns are often hidden, and they go way beyond side effects. So if we look at an old asthma study, for example, this is the percentage of patients who stated that they agreed or strongly agreed with each of the statements going down the left-hand side. I sometimes worry about the long-term effects of this inhaler. This was ICS, inhaled corticosteroids. I sometimes worry about becoming too dependent, 36%. Having to take this inhaler worries me. It's disruptive to my life. The inhaler causes unpleasant side effects. Well, that's there, but it's 11%. More common concerns are around beliefs about long-term effects and the dangers of becoming too dependent. And this is also true right across all the long-term conditions we've studied, which is very many in this space. So how can we understand why someone would go to the doctor, who presumably they trust, and then decide not to follow the advice. What's the origin of these beliefs? Well, in terms of doubts about necessity, it's often linked to the way in which the person experiences and thinks about the condition, which may be very different to the medical view. And in order to perceive a sort of logic of taking something long-term, we need to see a common sense fit between our understanding of the problem, the illness, and the proposed solution, the treatment. And for many patients, that fit isn't clear. Just telling them how the medicines work or how to take it, or even just teaching them how to do it, is not enough. We also need to tell the story in a way that overcomes common sense defaults in the way that people think about medicine. So common sense default is a sort of term I've coined to describe common ways or ideas, ways that people think about treatments and illness, which unless you uncover them and change them, will lead the person to conclude that it's not a good idea for me to continue this. And we don't have time to go into these in details, but here are a few examples. The first one is no symptoms, no problem. I have an inhaled corticosteroid if I'm a patient with asthma, sometimes prescribed regularly, but my asthma comes and goes. Do I really need the steroid inhaler when I don't have symptoms? And also, I might have an expectation of symptoms being resolved very quickly. The symptoms don't get resolved. I think, well, is this really worth it? It's not doing what I'm expecting. The symptoms are resolved. So I conclude, well, there's no point in continuing, job done. So these are all different beliefs that people can have about the necessity for an inhaler, which when you look at them are entirely logical, but based on the prescription and the evidence are mistaken. Other examples of common sense defaults are chemicals bad, natural good. I've had many patients in our research talk about steroids as being chemical and not liking the idea of putting a chemical into their body every day. The idea that medicines accumulate over time. You want me to take this stuff for the rest of my life. How much, medicine or chemicals am I putting into my body over that time? More powerful medicines are more harmful. That goes a long way. Goes back a long way, The ancient Greeks had one word for medicine and poison, pharmakon, which is where we get pharmaceuticals. So if you tell a patient this is really effective, it's a strong medicine, often that will come with an increased concern. What damage is it doing? Suspicion of the pharmaceutical industry, and also this idea of disease stereotypes. What do I expect from this condition? An asthma stereotype would be that it comes and goes, or prototype, and therefore I can just treat it when I get the symptoms. For many patients that might be true, but we still think for patients on the more severe spectrum, regular treatment is probably a better idea. And there's also, people often differentiate between different types of treatment. So for example, many patients feel very attached to their SABA because they feel symptom relief. They have high perceived necessity. It saved me. I've always have to have one with me. Low concerns. I don't like having to depend on it, but it's better than taking a steroid. Whereas often for ICS-based therapy, they have low perceived necessity. SABA works for me. And high concerns. It's a steroid. And we need to change. If we want to improve adherence, we need to change those beliefs around. So how do we do this? We don't need this one. So what solutions can we effect? Well, when we're looking at improving adherence, people often ask, would it be a solution to add an app or to put an extra nurse in the clinic? It's always useful to have an extra nurse in the clinic, but actually, in a way, this is the wrong question because the app and the nurse are delivery vehicles. It's the channel. What really counts is what the app and the nurse does. And therefore, we need to focus on the content. Context, as I'll come on to, is also important. Let's look at the content. Patients often have opposing views. They trust the clinician, but not the treatment, but they don't tell the clinician because they think if they do, the clinician will interpret that as a lack of trust in them. So often these beliefs and behaviors are completely hidden. They're under the surface. So the first thing that we need to do, and this is a 3-step perceptions and practicalities approach, which is recommended in the NICE adherence guidelines. Yes, there are guidelines for adherence. And we have to start with a no-blame approach that facilitates an honest and open discussion, that recognizes that non-adherence is the norm rather than the exception. Then we need to address 3 things. Firstly, necessity beliefs. We need to communicate a common sense story for why the treatment is needed, taking account of patients' perceptions and about their treatment and the illness and symptom expectations. We need to elicit and address concerns. And third, make it as easy and convenient as possible and help them to learn inhaler technique. So just those 3 simple principles could make a big difference. And there's a lot of evidence that if we apply that, here are some examples from across various clinical conditions with changes in behavior clearly shown there, that, if we apply that, we can change adherence and improve it. What about the channel? Well, we've delivered PAPA-based approaches through community pharmacies, and they are cost-effective to the NHS. There's several examples there. But also more recently, we've developed an app as a digital tool that can plug into more comprehensive apps or patient support platforms. And what this does is it's 3 components. It profiles the patient to identify doubts about necessity, concerns about the medication, and practical difficulties, and then through an algorithmic approach provides personal support to overcome them. And there's evidence in a proof of principle study in IBD that this changes beliefs compared to best case NHS care, with greater beliefs in necessity, significantly lower concerns, and increased adherence. There are several examples of how you can use, when you're delivering text reminders, you can make them more behaviorally intelligent, so they address not just remember to take it, but address necessity beliefs and concerns, and we have several practical examples of that. Context is also important. What works in one healthcare system may not work entirely in another, but generally the principles are the same because we are dealing with humans, and these models of behavior work for humans. So finally, adherence support should, I think, be a part of the value proposition of any treatment or technology. And the good news is that we can look beyond the clinic. It's important that the doctor or nurse leads the adherence support, but much of it can be done and achieved outside the clinic. And examples of that are the Persignia app, or web-based or even paper-based approaches that help land the treatment with the patient outside the clinic. And I believe that effective adherence support should be part of the value proposition of prescribed medicines. So I hope that was vaguely interesting, and thank you very much for listening. I think it's just time for some questions.